There are 5 questions of INICET PG 2025. This is also a moderately good paper with ear 2 questions, nose 1 question, pharynx 2 questions, and larynx 1 question. There are only 6 questions. We'll deal faster. So this was very good question. This is again resident level, PG level, ENT PG level question, not NEET PG level question. So a child developed limb spasms, pain, difficulty in mouth opening after ear infection. So spasms of the limb, inability to open mouth after ear infection. So there is no myelopathy question here. People rule out myelopathy easily. Bejeweled abscess, yes. Sigmoid sinus thrombus, yes. Tetanus, yes. So inability to open mouth is also known as lockjaw in few cases, or trismus in other cases. These both spasms and lockjaw typically point towards tetanus. It is not sigmoid sinus thrombus or Bejeweled abscess as some other centers describe. It is mainly otogenic tetanus. Why this is happening, sir? Any wound in a body gives entry to the bacteria known as Clostridium tetani. It can be CSOM, it can be any wound, it can be aberration, it can be laceration. Tetanus caused by tetanospasmin toxin, which gives spasms to the muscles, leading to your classical pain. It gives lockjaw because it gives spasm to the muscles. Your difficulty in opening the mouth happens because of this spasm of the muscles. So answer for this question is not sigmoid sinus thrombus. Sigmoid sinus thrombus doesn't throw trismus and limb spasms. Sigmoid sinus thrombosis causes what? IJV thrombus that goes to other sides, causes problem. Otherwise, it causes Grissinger's sign with edema over the mastoid with IJV edema. So which of the following are the indications for cochlear implantation? So you all know that cochlear implantation is implant into the cochlea. So where do you do that? It is typically done in sensorineural hearing loss. Typically done in sensorineural hearing loss. So indirectly they are asking which of the following cause sensorineural hearing loss? Will otosclerosis cause sensorineural hearing loss? No. It is thickening of stapes, pregnant female. So thickening of stapes, it's mainly conductive hearing loss. Fixed malleus, does it cause conductive hearing loss or sensorineural hearing loss? It causes conductive hearing loss. Malleus ossicle fixed, it is conductive hearing loss. So ototoxicity, yes, it is sensorineural hearing loss. Congenital hearing loss, yes, it is. Congenital could be sensorineural hearing loss. It could be conductive, it could be sensorineural, but majority of the congenital hearing loss are sensorineural. So option 2 and 4 are the correct answers for this question. Very easy question, nothing to remember. Cochlear implants are done in case of severe to profound sensorineural hearing loss. Out of the question, congenital and ototoxicity causes sensorineural hearing loss. A patient experiences vertigo and vomiting, especially when turning in the bed. So that means he is telling vertigo is there. And deafness was not mentioned, tinnitus was not mentioned. So therefore, I can rule out Meniere's disease. Sir, turning in bed means what? There is a positional variation. So typically you have positional impact on BPPV. Elsewhere you will not have this problem. And if they ask you for seconds, it is typically this vertigo lasts for seconds and goes off. Then it is BPPV. When it lasts for hours, then it is Meniere's disease. When it lasts for days, it is vestibular neuritis. So there is no triad of vertigo, deafness, and tinnitus. Therefore, I have ruled out Meniere's disease. Sir, vestibular neuritis, it is neuritis. It is viral infection followed by vertigo. It's typical history for vestibular neuritis. There should be viral infection while in the question. A patient had cold cough. Later he developed vertigo that lasted for days and subsided later on. Could be a history for vestibular neuritis. Labyrinthitis, yes, it can be followed or cannot be followed. But here there is turning in bed point which doesn't point the diagnosis of labyrinthitis. So answer for this question is A, BPPV. So because of brief episodes of positional changes are typically while rolling in the bed, looking up or bending forward. Or next history, next exam they will ask you, patient got up from the bed, typically he got vertigo. or any positional change, immediately BPPV. Any positional change, immediately BPPV. This is the second time they ask this question. Positional change, BPPV is the answer. So which of the following cranial nerves is not involved in olfaction? So I typically thought this question in dopamine search. Just have a look. So which of the following nerves is not involved in olfaction? The answer is D, hypoglossal nerve. So there are two types to answer this question. One type 1 is you can tell that hypoglossal is purely motor. It's not dealing with any sensory function. That way you can answer. Why it is motor? It controls tongue movements. So, sir, why olfaction? Olfactory nerve is one. There is no option of cranial nerve 1. So there are two types of olfaction. One is orthonasal or anterograde. I breathe from front of the nose. It is orthonasal or anterograde. Cranial nerve 1 helps in that. Retronasal is typically due to your taste. You stimulate the taste fibers by your facial nerve, lingual nerve, whatever the muscles you have. That will help. So retronasal olfaction, that is olfaction from behind, is due to your chorda tympani, that is facial nerve, or your glossopharyngeal nerve, or your vagus nerve helps in that. Then where does this trigeminal nerve helps? You know that ammonia can be smelled and it can irritate the olfactory fibers. In the same way, ammonia can also be tasted. If you get some acid or with containing ammonia, it can be smelled. So therefore your taste stimulates your partially your fifth nerve also. So therefore the nerve which is not involved in olfaction is hypoglossal nerve. Hypoglossal nerve. Answer for this is option D, not involved in hypoglossal. So you can answer in two ways. One way you can tell that it's a motor nerve, so not involved in olfaction. Other way you can tell that it is retronasal olfaction regarding the question. Which of the following statements is incorrect? Again JNA, again JNA. Recurrent epistaxis about JNA, juvenile nasopharyngeal, which is false. Recurrent epistaxis, yes, it is correct. It can cause unilateral obstruction. Yes, you have seen in the earlier picture that is causing unilateral obstruction. Exclusively seen in adolescent males, correct. I told adolescent male disease, absence of muscular coat, puberty, it's a testosterone dependent puberty age group tumor, so testosterone dependent tumor, absence of muscle coat, therefore the clotting doesn't happen, therefore there will be recurrent profuse painless epistaxis with nasal obstruction because of mass, and this deformity of face is known as frog face deformity, and the CT scan picture is Holman-Miller sign. Never ever do biopsy because this is a vascular tumor. It will bleed profusely if you do biopsy. No biopsy in these patients. Treatment is what? Surgical excision of the tumor. So it's a recurrent profuse bleeding due to vascularity. Biopsy is always contraindicated in this patient. Diagnosis is done by imaging, typically CECT, which shows Andrel sign or Holman-Miller sign. Every year, every exam, one question will be on this topic. So stridor in a newborn is commonly seen in which of the following conditions? Laryngomalacia, subglottic stenosis, laryngeal papilloma, hemorrhagic polyps. So it is typically laryngeal papilloma is seen in children but not in the newborn. It is typically seen in children but not in newborn. Hemorrhagic polyp can usually seen in adults or children. It is very rare to happen but can happen. But he is asking typically a newborn or birth patient, newborn or just born patient. So the answer is laryngomalacia or subglottic stenosis. For your future exams, I am showing the list. Don't worry, get worried. So stridor or stridor part of nasopharynx is mainly due to nasal block or any other causes in children and neonates. But the stridor part is mainly due to your laryngeal and tracheal part. So if you see this box alone, so in a newborn, in a neonate, it is mainly due to laryngomalacia or a stenosis, subglottic stenosis, or a vocal cord palsy, or a reflex laryngitis, or intubation trauma can result in newborn having stridor. By tracheal cause, it is again tracheobronchomalacia like laryngomalacia, laryngeal stenosis, tracheal stenosis. Any vascular compression of the trachea can also cause newborn neonate stridor. But in children, the stridor is mainly due to croup, hemangioma, papillomatosis, intubation trauma, vocal cord palsy. Tracheal stridor is mainly due to foreign body and tracheal stenosis. So try to understand. Major cause would be, most common cause of all these is laryngomalacia. Congenital laryngeal stridor or stridor in children is more commonly due to your laryngomalacia. So laryngomalacia should be there in the options. The next option is congenital subglottic stenosis. You have a classification for that, which was a repeat question. What is the classification? Cotton-Mayer grading, Cotton-Mayer staging, whatever. Next question, this was also dealt in the previous classes. If the pyriform fossa is injured due to a fishbone, which nerve is most likely to be damaged? Answer is internal laryngeal nerve. It's not vagus, it's not recurrent, it is not nasopharyngeal. So what is this internal laryngeal nerve? Your vagus exits the skull base and comes to the level of hyoid and divides into your superior laryngeal nerve and recurrent laryngeal nerve. The recurrent laryngeal nerve goes down, and on the left side it goes to the mediastinum and turns and comes towards the thyroid part. That is secondary. Now superior laryngeal nerve at the level of hyoid, it pierces the mucosa of the thyroid membrane and goes into larynx, that is known as internal laryngeal nerve. Another part of the superior laryngeal nerve comes and supplies your cricothyroid muscle, because this cricoid, this is thyroid, there is a muscle known as cricothyroid muscle. So this is known as external laryngeal nerve or external branch of superior laryngeal nerve. So therefore superior laryngeal nerve has two parts which supplies interior of the larynx known as interior of larynx, so it's called internal laryngeal nerve or ILN. External part supplies because it's outside cricothyroid, it's outside, supplies the cricothyroid muscle. So this is the basic concept. Yes, internal laryngeal nerve is a part of vagus, but vagus has recurrent laryngeal nerve, superior laryngeal nerve. To be specific in the question, he is asking pyriform fossa. So you can see this is the pyriform fossa or pyriform recess here. So in this part, it is mainly supplied by internal laryngeal nerve. So I have shown you that it enters into at the level of hyoid and it branches to the epiglottis here. Level 2, it supplies the lateral part of the larynx. Level 3, it is supplying this pyriform sinus area. So the supply of pyriform sinus is by internal laryngeal nerve. Internal laryngeal nerve, which is a branch of superior laryngeal nerve, supplies the mucosa of the pyriform sinus. Then next year, one more question was asked. This was a question that was shown in the next year. So what are you blocking? What are you blocking here? So if you see in this patient, what he is trying to block is internal laryngeal nerve. So you can see two branches like this here. One branch here, another branch here. So this is external branch which is supplying the cricothyroid muscle. This is cricothyroid muscle. This is internal branch which is piercing the larynx. So that is why, so the nerve which pierces the larynx is known as internal branch of superior laryngeal nerve. The other nerve which comes like this and supplies the cricothyroid is known as your external branch of superior laryngeal nerve. It's going internal, so it's called internal branch. Sir, what will I do? What is this picture? If you do little higher block, it is known as superior laryngeal nerve block. If you block here the nerve, then it is known as superior laryngeal nerve block. If you block when it's entering this mucosa, then it is known as internal laryngeal block. Superior laryngeal nerve has two parts, internal laryngeal nerve, external laryngeal nerve. External laryngeal nerve, no one blocks because external branch of superior laryngeal nerve, because supplying the muscle action. So we have two nerves to block, sensory nerve, superior laryngeal nerve and internal branch. So internal branch picture is shown, that was asked in the previous question. So this is about INICET exam.